Okay, let's unpack this Wolff-Parkinson White Syndrome, or WPW. You shared some notes, and our goal here is to really boil it down.
Exactly. Cut through the noise and find that exam gold, the stuff you need to remember.
Think of this as your high-yield WPW survival guide. We'll cover what it is, why it happens.
How to spot it, and importantly, what to do about it. Keep it sharp, keep it memorable.
Right, so WPW, what exactly is it in simple terms?
Okay, so WTW is a congenital heart thing. Means you're born with it. There's an extra electrical connection.
An extra pathway.
Yeah, between the atria and ventricles. It's called the bundle of Kent.
The bundle of Kent, okay.
And this path acts like a shortcut, bypassing the normal route. This can cause the ventricles to, well, fire off too early. That's pre-excitation.
And that leads to?
It can lead to a really fast heartbeat, a type of supraventricular tachycardia, SVT. Think of it as an unauthorized fast lane in the heart's wiring.
Got it. So this extra pathway, the bundle of Kent, where does it actually come from? Why is it there?
That's the thing. In most cases, we don't actually know the exact cause. It's often just there.
Spontaneous.
Often, yeah. But sometimes there's a genetic link. Mutations in a specific gene, PRKG, have been implicated.
PRKG too.
Yeah.
So it can run in families.
It can, yes.
Yeah.
And WPW is also sometimes seen with other congenital heart issues, like Ebstein's anomaly.
Ebstein's.
Yeah.
Right. And in those cases, could there be more than one extra pathway?
Absolutely. Sometimes there are multiple accessory pathways, which complicates things a bit.
Okay. Are there other conditions or factors that make WPW more likely or maybe make the symptoms worse?
Well, aside from the genetic link and Ebstein's, it's sometimes associated with things like hypertrophic cardiomyopathy, HOCM,
Okay.
mitral valve prolapse, MVP, and even an overactive thyrotoxicosis.
Right, thyrotoxicosis. Let's dig into the mechanism a bit more. This bundle of Kent, how does it cause trouble?
This is really the core of it. So normally the electrical signal goes through the AV node.
The AV node acts like a gatekeeper, slows things down a bit, right?
Precisely. It creates a necessary delay. But the bundle of Kent, it bypasses this gatekeeper entirely.
Ah, so the signal gets through too fast.
Exactly. It conducts electricity much faster than the AV node. This rapid conduction is what can lead to those really fast heart rates, like SVT.
And potential instability.
Yes, and in rarer situations, it can even degenerate into ventricular fibrillation, which is obviously life-threatening.
Wow. And that PRKG2 gene you mentioned.
Yeah, it codes for a type of enzyme, a protein kinase. It gives us a little window into the, the molecular side of things, but it's complex.
Okay. Now, I remember there are types of WPW, type A and type B. How do we tell them apart, especially on an ECG?
Correct. It's not one size fits all. The classification is based on where that accessory pathway is located.
And that changes the ECG.
Significantly. So type A, think of the pathway being on the left side of the heart.
Left side, okay.
On the ECG, you often see a positive delta wave in lead V1. A good mnemonic is A for away from V1 positive.
Positive delta in V1. Got it. Anything else?
You might also see right axis deviation, and sometimes it can even look a bit like a right bundle branch block.
Okay. And type B?
Type B is actually more common. Here, the pathway is typically on the right side.
Right-sided pathway.
And on the ECG, you usually see a negative delta wave in V1. So think B4 back towards V1 negative.
Negative delta in V1. Makes sense.
Type B also often shows left axis deviation and can sometimes resemble a left bundle branch block pattern.
So key differences in V1 delta wave direction and axis. Good tip. How does WPW actually present? What might a patient experience?
It's interesting because many people with WPW have absolutely no symptoms. It might just be picked up on a routine ECG.
An incidental finding.
Often, yes. But when symptoms do occur, palpitations are really common. That feeling of the heart racing, fluttering, skipping beats.
Palpitations. What else?
Lightheadedness, dizziness, sometimes even syncope, fainting. And of course, tachycardia, a heart rate over 100.
Fainting. Okay. I also saw a mention of polyuria. Frequent urination.
Yes, that can happen too. When the atria are stretched by the fast rate or pressure, they release atrial natriuretic peptide, which makes you pee more.
Fascinating. And the most serious presentation.
Very rarely, tragically, the first sign can be ventricular fibrillation leading to sudden cardiac death. It's uncommon, but it's why diagnosis is important.
Definitely. How common is WPW overall? Who gets it?
It's one of the more common pre-excitation syndromes. Estimates are around 1 to 3 people per 1,000.
So not super rare.
Not incredibly rare, no, and it seems to be slightly more common in males.
And even though it's congenital, present from birth.
It often doesn't show up symptomatically until the teenage years or early adulthood. That's when episodes of SVT might start.
Interesting. Does it change with age?
Yeah, the prevalence actually tends to decrease as people get older. It's thought maybe the accessory pathway function can decline over time, perhaps due to fibrosis.
Okay, let's talk diagnosis. How do we confirm it? You mentioned the ECG is key.
Absolutely. The ECG is the cornerstone. You're looking for that classic triad.
The triad.
A short PR interval because the signal bypasses the AV node delay, a delta wave that's slurred, slow upstroke at the beginning of the QRS.
Like a little ramp instead of a sharp start.
Exactly. Picture a gentle slope, and because of that early activation via the shortcut, a widened QRS complex.
Okay, so the key takeaway. Short PR, slurred QRS delta wave, E equals WPW.
That's the mantra. Short PR, slurred QRS.
What other tests might be useful?
An echocardiogram is important to check for any underlying structural heart disease, like Ebstein's or HOCM.
Makes sense. What about catching arrhythmias that aren't always there?
Right. For that, you might use an exercise stress test or Holter monitoring wearing a portable ECG monitor for 24, 48 hours or longer.
Holter monitor. Okay. And what about really pinpointing the pathway?
For that, the gold standard is often an electrophysiological study, or EPS.
EPS, what does that involve?
It involves inserting catheters with electrodes into the heart to map the electrical activity precisely. It can locate the exact spot of the accessory pathway.
And that's crucial for treatment planning.
Absolutely. EPS directly guides management, especially ablation. Sometimes a cardiac MRI might also be used to look closely at the heart structure.
Right, let's move to management. We've diagnosed WPW. What now?
It really depends. Is the patient symptomatic?
Okay, scenario 1, asymptomatic, found on ECG, feels fine.
Often, these individuals just need regular follow-up, maybe some risk assessment, but no immediate treatment might be needed if they are low risk.
Okay, scenario 2, symptomatic, having palpitations, SVT.
No, treatment is necessary. If someone is hemodynamically unstable, like very low blood pressure during an episode,
Critically unwell.
then the immediate step is usually synchronized DC cardioversion, an electrical shock to reset the rhythm.
Cardioversion, got it. What if they're stable but having an episode?
You can try vagal maneuvers first, things like bearing down, the Valsalva maneuver.
Simple first step, if that doesn't work.
Medications like adenosine can be used to block the AV node and potentially stop the SVT, but big caution here, avoid adenosine if the patient is in atrial fibrillation with WTW.
Why is that?
Because blocking the AV node can force all the rapid atrial signals down the accessory pathway, potentially leading to very fast ventricular rates, even VFib. Same caution applies to drugs like digoxin and verapamil, especially as single agents in WPW with AFib.
Okay, crucial safety point. Avoid AV nodal blockers like adenosine, digoxin, verapamil if AFib is present in WPW. What about long-term management?
For ongoing symptoms, you can use medications to prevent episodes, drugs like flecainide, propafenone, or sometimes amiodarone or sotalol.
So rate or rhythm control drugs, is there a more definitive fix?
Yes. The definitive treatment, and often the preferred long-term strategy for symptomatic patients, is radiofrequency catheter ablation.
Ablation, how does that work?
Using catheters guided by EPS mapping, radiofrequency energy like heat is delivered to the tip of the catheter to destroy the accessory pathway tissue.
Basically cauterizing that electrical shortcut.
Exactly. It's highly effective, often curative.
Are there other considerations? Like driving?
Yes, definitely. There are specific guidelines, like the DVLA rules in the UK. People with symptomatic WPW might face restrictions, especially with heavy goods vehicles or passenger transport, and they need to inform the licensing authority.
And when would you consider ablation, even in someone without symptoms?
That's a good question. It might be considered in asymptomatic individuals if they have high-risk features identified during EPS, a family history of sudden cardiac death, or if their profession or lifestyle demands it, think pilots, competitive athletes.
Or if the Ebstein's anomaly is present with multiple pathways.
Yes, though ablation can be more challenging in those cases, it's still often attempted.
What are the main dangers or complications we worry about with WPW? And what's the general outlook?
The biggest worry is always that small but real risk of ventricular arrhythmias, particularly VFib, leading to sudden cardiac death.
Which is rare, but serious.
Very rare, estimated around 0.1% per year, or even lower in some groups, but it's the most feared complication. The risk is a bit higher in males, younger patients, those with a history of symptomatic arrhythmias like AFib or AVRT or multiple pathway.
That the prognosis after treatment.
After successful ablation, the prognosis is generally excellent. It's often considered a cure. And as we mentioned, even without ablation, the pathway's ability to conduct rapidly seems to decrease over time for some people.
It's reassuring. Finally, before we wrap up, what other conditions might look like WPW or cause similar symptoms, the differential diagnosis?
Yeah, important to keep other things in mind. Other causes of palpitations or SVT, like typical AV-NRT or other forms of AVRT,
Okay.
atrial fibrillation or flutter without WPW. Ventricular tachycardia needs to be ruled out, especially if the QRS is wide.
And ECG mimics.
Sometimes things like a right bundle branch block or even signs of a posterior myocardial infarction could potentially be confused if you're not looking carefully for that classic WPW triad. And non-cardiac causes of palpitations like thyrotoxicosis.
Great overview. So, wrapping it all up, what's the bottom line for our listeners?
You now have, hopefully, a really solid, high-yield handle on WPW syndrome.
Focus on those key takeaways. Remember the ECG, short PR interval, delta wave, slurred QRS, widened QRS. Notice that bundle of Kent causing the mischief.
Understand the risk of rapid heart rates like SVT, the rare but serious risk of VFib, and that ablation is often the definitive treatment for symptomatic patients. Be cautious with AV nodal blockers if AFib is present.
This deep dive should give you a strong foundation. If you want to really cement this knowledge, do more questions, get more in-depth revision.
Head over to passthemsra.com. Loads of resources there.
And don't forget the free materials available at freemsra.com too.
Definitely worth checking out.
So go think about those electrical shortcuts in the heart. And good luck with your revision.